what you have done before in this module related to community medicine. So the learning objectives for today's lecture are, we'll give the definition of maternal death, then identify the global causes of maternal death, and we'll assess the maternal mortality trends globally, and we'll be defining the Millennium Development Goal number 5, and then the Sustainable Development Goal and the target, which is related to the safe motherhood. And we'll give the definition of safe motherhood, then analyze the global safe motherhood initiative, which was taken for this in 1987. And then we'll be looking at the pillars of the safe motherhood and analyze the 3 delay model and the factors affecting the 3 delays, and then identify the strategies to prevent the 3 delays. And then we'll be doing that, how define the continuum of care and its dimensions. So starting with the topic, that is the safe motherhood initiative. What is motherhood? Motherhood is a state of being a mother, that is a female giving birth to a child and then childbearing. So all the things which are surrounding her and going and through which she is going, that is what is the motherhood. So starting with the definition of maternal health, maternal death. Death of a woman while pregnant or within 42 days of termination of pregnancy, that is irrespective of the site and duration of pregnancy, by the causes related to or aggravated by pregnancy or its management, but not due to any accidental or incidental cause. So this is how the maternal death or death of a mother is defined, that if a female dies while she is pregnant or within 42 days of a birth of a child, then this is called the maternal death, and the cause should be related to the pregnancy, not by accident or incident. And this is the definition, and the formula how we calculate is also calculated. The maternal mortality rate is also calculated in the same way. I'll tell you further in the lecture. The global causes of maternal mortality. There are certain direct causes and indirect causes of maternal death. So the direct maternal death, the direct obstetric death, or the obstetric cause leading to the death of the mother, that is the result of a complication of pregnancy, maybe any complication during pregnancy, and then delivery or management of the two, which has led to the death of the mother. So they may be, the examples are BPH, that is the postpartum hemorrhage, sepsis, that is infection, eclampsia, that is due to hypertension, and maybe obstructed labor. So these are the direct maternal death causes. BPH, which is causes about 35% of death in mothers. That is, its prevalence is very high. And indirect maternal death, indirect obstetric death are those maternal deaths that result from the previous existing disease or disease that may develop during pregnancy and not due to the direct obstetric cause, but were aggravated by the physiological effects of pregnancy. So any cause that is not direct obstetric cause and it may lead to maternal death, death of the mother during pregnancy, is the indirect cause of maternal death. And deaths due to aggravation by pregnancy of an existing cardiac disease or renal disease are most common because during pregnancy there's a physiological increase in blood volume, heart rate, and cardiac output. So patient with underlying cardiac disorder is unable to tolerate these changes well. So the mother is at the risk of developing arrhythmias, pulmonary edema, and congestive heart failure. So here the cardiac disease may aggravate or during pregnancy, and the common causes are the congenital heart defects. So if a mother has a congenital heart disease, the 60% of cases are due to patent ductus arteriosus or atrial septic defect or ventricular septic defect. So these cardiac problems in the mother can aggravate during pregnancy. And renal disease, chronic renal disease is often clinically and biochemically silent until renal impairment is advanced. So pregnant women with chronic renal disease adapts poorly to this, and there is increase in renal blood flow, and so increased decline in the renal function, and this may lead to poor pregnancy outcome. So if a mother is suffering from cardiac disease or renal disease, so these may aggravate during pregnancy and they may become the cause of maternal death. Global distribution of the causes of maternal mortality. So the direct causes generally contribute to about 20% of cases of maternal deaths, and indirect causes about 20%. Indirect causes, hemorrhage is the leading cause. So 35% of deaths in mothers are due to hemorrhage. That may be APH, that is antepartum hemorrhage or postpartum hemorrhage, contributing the most. And then hypertension leading to preeclampsia and eclampsia, then infection, that is sepsis, abortion, and the other direct causes. These are the statistics worldwide. Women of reproductive age, that is 15 to 49 years of age, 51% of women are anemic, 14% are thin or undernourished. And in pregnant females, 63% of the females do not receive 4 or more antenatal care visits. So majority are not getting the antenatal care. 41% do not receive 2 tetanus toxoid vaccines, and only 22% consume iron and folic acid supplements for more than 90 days. And the maternal mortality ratio is 178 per 100,000 live births. And in children, so when the mother is not well, the children will also suffer. So 55% neonatal mortality rate per 1,000 live births, 25% babies are low birth weight, and 45% have there is stunting in children under 5 years, and 11% wasting in children under 5 years. Maternal mortality global trends. So maternal mortality ratio in 1990 was 850 maternal deaths per 100,000 live births. So we define maternal mortality ratio as the number of maternal deaths or estimated or recorded maternal deaths during pregnancy or within 42 days after the delivery, divided by the total number of live births in the same period, multiplied by 100,000. So this is how we calculate this. So in 1990, we can see it was 850, and then in 2000, it was reduced to about, due to this initiative, Safe Motherhood initiative, the maternal mortality reduced to about more than half, that is 400 maternal deaths per 100,000 live births. And then in 2015, the statistics were 216 maternal deaths per 100,000 live births, and in 2017, 211 maternal deaths per 100,000 live births. So 95% of all maternal deaths occur in low and lower middle income countries. Because we know the reason behind that antenatal care is not proper and the female does not visit the antenatal clinic. So if the high-risk pregnancies are not identified, young adolescents aged 10 to 14 face a higher risk of complications and death as a result of pregnancy than other women. So very young girls who become pregnant may have a higher risk of complications. Now the situation in Pakistan. These are the latest figures which were given in the Pakistan Maternal Mortality Survey in 2019. And this is that we have maternal mortality ratio 186 per 100,000 live births in Pakistan. The crude birth rate is 27 births per 1,000 population. Crude death rate is 7.28 deaths per 1,000 population. And percentage of women using modern contraceptives is 34%. And total fertility rate is 3.4 children born per woman. So more than 3 women bears nearly 3 children. Every woman in Pakistan bears nearly 3 children. So these are the figures. And still maternal mortality is very high. As you can see, it is 186. And we'll see in different provinces. Punjab having 157, that is better than Sindh and Balochistan. Khyber Pakhtunkhwa is number 2, that is 165 maternal deaths per 100,000. Then Sindh 224, the situation is not good, and Balochistan it is worse, that is 298 per 100,000. So, and in Gilgit-Baltistan it is 157, in Jammu Kashmir it's 104. So these are the latest statistics here. So on average, the Pakistan is having 186 maternal deaths per 100,000 live births. Per 100,000, not. The Millennium Development Goals. The target 5A was to reduce the maternal mortality by 3/4 between 1990 to 2015. And target 5B was to achieve by 2015 the universal access to reproductive health, that every woman must have access to reproductive health. So in order to monitor the indicators were contraceptive prevalence rate, that how much contraceptives are being used, the adolescent birth rate, then antenatal care coverage, and unmet need for family planning. So Millennium Development Goals were developed from 2000 to 2015, and 189 countries joined this, and there were 8 goals, and these were related to maternal health. Then Sustainable Development Goals. The Millennium Development Goals were transformed to 2030 agenda, and for Sustainable Development Goals, and the goals were increased from 8 to 17. So those goals related to the well-being of a family are to ensure healthy lives and promote well-being for all at all ages was goal number 3, and then 3.1 was maternal mortality should be reduced to 70 per 1,000 live births by year 2030. So these are the Sustainable Development Goals to be achieved by 2030. The Safe Motherhood Initiative, which we are discussing today, was launched in 1987, and UNICEF, WHO, and United Nations Population Fund Agency and JICA, they were all pioneers in launching this Safe Motherhood project in Pakistan, and it aims at ensuring a safe outcome of pregnancy for both mother and child, and it includes an intervention which improves maternal health, make childbirth safe, and reduce maternal mortality and morbidity. So Pakistan is signatory to Safe Motherhood Initiative, and it was started here in 1990. Efforts are made through Social Action Plan, and it aims at 50% reduction in maternal morbidity and mortality. The pillars of safe motherhood. This is the old diagram which is showing the safe motherhood. And the pillars here are family planning, antenatal care, clean and safe delivery, and essential obstetric care. 2 more have been added, that are the abortion care and the care for STI and HIV, or STI, sexually transmitted disease, and HIV control. And the base is the basic maternity care, primary health care, and equity for women. This is the latest one. Abortion care and STD and HIV control is added into it, and the same primary health care, equity for women, and communication for behavior change, that is giving right to everyone for the reproductive health. Pillars and interventions of Safe Motherhood Initiative. The main pillars were family planning to reduce the number of high risk and unwanted pregnancies. So the WHO definition of family planning is that family planning allows individuals and couples to anticipate and attain their desired number of children and spacing and timing of their birth. It is achieved through use of contraceptive methods and treatment of involuntary fertility. So the choice, informed choice, is given to individuals and couples that they should decide and for family planning to reduce the number of high risk and unwanted pregnancies. So to use the contraceptive methods for this purpose, that high risk and unwanted pregnancies which may lead to maternal death or maternal increase in the maternal mortality and the infant mortality, we need to reduce that. So antenatal care for prevention and early detection of problems in pregnancy. If a female is going for antenatal visits, then the problems may be detected earlier and may be dealt with during pregnancy. Clean, safe delivery to decrease the number of obstetric complications. Then essential obstetric care for timely and effective management of any obstetric complication if it occurs. It is a natural process, the birth of a child, but there certain complications may occur. The foundation for making motherhood safe, WHO has recommended 4 strategic interventions of 4 pillars. Now it's 6 pillars, which should be delivered through primary health care on the foundation of equity for women, primary health care, and basic maternity care. So as we define the family planning, it is the informed choice, and the recommended intervals here are at least 2 years after a live birth. So the couple should plan the next child at least after 2 years after a live birth, at least 6 months after a miscarriage or induced abortion. If a female has suffered a miscarriage or she had induced abortion due to some reason, then at least there must be a 6 months gap or interval. Intervals less than 6 months pose increased risk of maternal mortality. Intervals less than 18 months or 5 years may increase risk of preeclampsia, leading to eclampsia, and then preterm birth, low birth weight, and small for gestational age infants. So then not only the mother suffers, but the baby also suffers due to this. Short intervals may lead to higher occurrence of induced abortions in areas where unsafe abortion is prevalent. This is a risk for mother. So if there is no proper family planning, then there's a risk to the mother's life as well as to baby's life. So this should be planned well. Factors for advising appropriate contraceptives. Female should be advised according to her age, parity, sex of her age, and sex of her children. Couples desire for further pregnancies, they should be counseled, and this should be their choice. Duration of birth spacing required, they should be informed about the consequences, and then they should decide. Previous obstetric history of mother, that is very important. whether she is breastfeeding currently, menstrual history regarding menorrhagia, and the associated medical problems. If a mother is suffering from any other disease, then it is a risk for her to become pregnant again and again. Couples compliance potential, and this is the most important factor relating to this. Antenatal care, often the only contact women have with the healthcare system. So this is the female in the lifetime may have only this contact with the healthcare system. Increases the likelihood of skilled or attendant at birth. So if a woman visits the antenatal care, or she takes the antenatal care, then she has increased chance that she will get a skilled birth attendant. Affords opportunity for micronutrient supplementation, that is vitamin A, iron, folate, and iodine. So if she's coming for antenatal care, she may receive this supplement. Opportunity for prevention of disease transmission, that is tetanus, HIV, and malaria. So antenatal care or antenatal visits are very important for the mother. Goals for antenatal care. Antenatal care helps women maintain normal pregnancies through focused assistance and individualized care. Antenatal care aims to detect and treat existing conditions or complications. So if a female is having a disease and she's not diagnosed before, so she may be diagnosed and then treated accordingly. Prevent complications and the disease, prepare for birth and be ready for the complications, and include the health promotion education. The WHO antenatal care model. The first trimester, contact 1 up to 12 weeks. So a female, when she's pregnant, she should have contact 1, that is, she should come to the antenatal clinic up to 12 weeks. The first visit should be after she's pregnant up to 12 weeks. Then in second trimester, the contact 2 is at 20 weeks, and then contact 3 at 26 weeks. Then in third trimester, the contact 4 at 30 weeks, then contact 5 after 4 weeks following the contact 4, that is 34 weeks. And then after 34 weeks, a woman should visit the antenatal clinic after every 2 weeks, that is 36 weeks, 38, and then 40 weeks. Return for delivery at 41 weeks if not given birth. If she does not have natural pains, then she can come for the induced one or whatever the decision of the caretaker. Note, intermittent preventive treatment of malaria in pregnancy should be started at greater than 13 weeks if malaria endemic area. Use of antenatal care. 70% of women worldwide have at least one antenatal visit with a skilled attendant. The use of antenatal care varies by region of the world, the level of income, the level of education, and then urban versus rural residents. Because in urban settings, we may have more antenatal clinics than rural settings. Women with higher income, higher education, and urban residents are more likely to use the antenatal care because maybe they are more aware, they are more independent, and they can use it as compared to the rural resident women. The routine functions, the routine tests which are done when a female comes to a antenatal clinic are urine for albumin, blood pressure, pelvic measurements so that the obstetric labor does not take place, then recording the weight of the mother, how she's going, the hemoglobin levels, which are very important. Otherwise, they result in APH and PPH, a general examination, and record keeping, advice to the mother about her health, and then followed by the baby's health, tetanus toxoid injection, which is given the tetanus toxoid immunization schedule for a woman of childbearing and pregnant women without previous exposure to TT. Is this how they are given? The first dose at first contact or as early as possible in pregnancy. And then second is given at least 4 weeks apart after TG1. And expected duration of protection is 1 to 3 years. So after first dose, the mother or the female is not protected, but if she receives the second dose, then she may be protected for 1 to 3 years. Then the third dose is given at least 6 months after TT2 or during the subsequent pregnancy. Then the fourth is given at least 1 year after TT3 or during subsequent pregnancy. And then fifth dose is at least 1 year after TT4 or during the subsequent pregnancy. So at least a woman should receive 2 doses of TT during pregnancy if she has not got any tetanus immunization before. This is the schedule. Clean, safe delivery to be conducted by a skilled birth attendant. The three cleans of a safe delivery are clean hands, clean surface, and clean cutting and tying of the cord. And this is very important to prevent the infections and sepsis, which may be a cause of death in mothers. The skilled birth attendant is an accredited health professional such as a midwife, a doctor, or a nurse. So this is very important that a female has a skilled birth attendant attending her at the time of delivery, have skills needed to manage normal and complicated pregnancies, childbirth, and immediate postnatal period, is able to identify, manage, or refer complications in mother and newborn. So this is very important that a skilled birth attendant is there for a mother. Essential obstetric care is a term used to describe the elements of obstetric care needed for the management of normal and complicated pregnancy, delivery, and the postpartum hemorrhage. So this is the whole set of care which is provided to the female. The elements is needed for the management of normal and complicated pregnancies, delivery, and even in the postpartum period. Because it's not like that mother gives birth to a child and then she's left. She needs the postpartum care also. Consists of facility for surgery. She needs ability to provide IV oxytocin, provision of anesthesia, availability of medical treatment for shock, sepsis, anemia, and hypertension, availability of blood transfusion, monitoring of labor, management of problem pregnancies, manual vacuum aspiration, and special care for neonates. So essential obstetric care facility should consist of all these facilities, and all these should be dealt with. Essential obstetric care consists of basic essential obstetric care and the comprehensive essential obstetric care. So here we divide this essential obstetric care into basic and comprehensive, and we will see that what is dealt in basic. The basic essential obstetric care includes all elements of essential obstetric care except surgery, anesthesia, and blood replacement, because that needs more expertise. So for that we need comprehensive care. So basic essential obstetric care services at the health center level should include at least the following: parenteral antibiotics, parenteral oxytocin drugs, parenteral sedatives for eclampsia, manual removal of placenta, manual removal of retained products, basic neonatal resuscitation care. So this is basic that should be provided at every healthcare center where a mother is giving birth to a child. Comprehensive essential obstetric care includes the obstetric care services at the district hospital level. First referral level should include all the basic essential care, plus the cesarean section, anesthesia, blood transfusion, and provision of care to sick and low birth weight newborns, including resuscitation. So if the delivery is not normal and it has some complication, then it should be referred from the basic health unit to district hospital level, and where this comprehensive essential obstetric care is available, and it is provided to the mother and even the child. Post-abortion care, it is necessary to prevent complications of abortion as well, because post-abortion care helps to identify and detect if there is any complication of abortion. Useful to refer other reproductive health problems when necessary, and an essential element of post-abortion care services is providing the woman with a family planning method before she leaves the facility. So this is very important. If a female who has had abortion due to any reason, so this post-abortion care is very important, so that to prevent the complications and she may be given the choice for the family planning as well. It also provides counseling and awareness about different family planning methods. So she is counseled about the different family planning methods, and it is her choice what she chooses. According to her age and parity, she is given the informed choice. STD, HIV, AIDS control. HIV screening is done to prevent and manage HIV and AIDS transmission to the baby. It is very important because this may disease is transmitted to the baby. To assess the risk of future infection, to provide the voluntary counseling and testing, to expand the services to address mother to child transmission. So the STD HIV control is a part of the Safe Motherhood initiative now. The 3 delays model, we discussed this. This is very important because if there is any one delay, it may lead to the death of the mother. Delays leading to maternal death are often multifactorial. So there's not just one reason or that may lead to mother's death, but there are multiple factors. Deaths can be prevented by reducing delays at 3 points or levels in the decision to seek care. So this is the decision of the family, decision of the female, but unfortunately at that time the female is not in a position to take the decision, and the family is mainly taking the decision. So in the decision to seek care at proper time, when reaching the healthcare facility and receiving the treatment at the facility, that if the mother has reached the facility or the healthcare center, but she does not receive any care or treatment, then that is the responsibility of that facility. Factors affecting the 3 delays. Delay 1, that is deciding to seek care. The factors affecting the service utilization and outcome may be socioeconomic and cultural characteristics, which may be responsible for delay 1, that is for decision taken to seek the care. So there are multiple cultural factors and socioeconomic factors in different countries which may lead to this. Then accessibility to health facilities, that how far is the health facility and how they are going to reach there. Then the quality of care provided at the health facility, right? The delay 2 may be identifying and reaching the health facility, that people may not know that where this essential obstetric care is provided. They may reach some facility and there they inform you that here they don't have the this obstetric clinic or something like that, and they have to move to some other place. Then the 3rd delay may be receiving the adequate and appropriate treatment, that the mother may have reached the facility, but the adequate and appropriate treatment is not available there, and there may be delay in this which may lead to maternal death. Danger to mother's life. So delay one is the onset, that you have to decide quickly, the recognition of the problem and then the decision. So then delay two may be in the transport, arranging the transport, reaching the facility, reaching the correct place, then arrival at the hospital, and then treatment begins. So arrival at the hospital, and then the adequate and proper treatment is given there. The facilities are available or not available. That may be the delay three. Delay in decision to seek care, the low status of the woman, social cultural barriers, poor understanding of complications and risk factors in pregnancy and when to seek medical help. The female may herself be not aware of the complications and the risk factors, and the family members, then previous poor experience of healthcare, that previously they might have gone to a healthcare facility and they didn't receive the care which was needed. So if they have this experience, then they will never go again. Then acceptance of the maternal death, that is very difficult. And then the financial implications, the traveling and whatever they have to arrange to reach the facility. So the delay in decision to seek care takes place, followed by how it can be prevented. Provide communities, men and women, with information on pregnancy, childbirth, and newborn health care, so they know when to seek medical help. So when a mother or the parents, both parents are going for the antenatal care, they should be well informed that when they need to come to a healthcare facility and when a mother needs help, they should be clearly informed and facilitate income generation schemes for women to enable them to become financially independent. Women should be independent in her decisions, that she can take her decision to go to a healthcare facility and empowered to make decisions about their own sexual and reproductive health. She should be the one to decide what she has to do and to become the future leaders. So this is very important. We can prevent the delay, first delay about the decision taking by providing information, by giving health education to the females, to the families, and then facilitate the income generation among females so that they are independent in taking their decision. Delay in reaching the care, the distance to healthcare centers and hospitals, the availability of the cost of transportation, then poor roads and infrastructure in our rural areas, geography, mountainous terrain, the rivers, and the poor referral system, that there may be delay in referring the patient. They may say that no, it's our center is well equipped and we can do, and in the end, they say we were unable to give the adequate care. How it can be prevented? Provision of health centers in rural and remote areas, as well as outreach healthcare visitors visiting villages to provide the care. So the health centers should be available in rural population and remote areas close to them. And if it is not possible to provide the center in every area or every village, then at least healthcare workers must be visiting these villages to provide the basic care. Building waiting houses next to health centers for expecting mothers to stay in before their due date, so when they go into labor, assistance is on site. So this should be also provided so that the mothers don't have to travel long when they are in labor. Provision of motorbike ambulances for mountainous terrains to improve access to health centers. Delay in receiving adequate health care, poor facilities, lack of medical supplies. This is very common in our system. And inadequately trained and poorly motivated medical staff. When they see the patient, they run away. This is not fair because they are not well trained. They are unable to handle the emergencies. Inadequate referral system. The patients are not referred on time. Poor training and lack of motivation of personnel, and then the lack of finances. So these may be the hindrances which may lead to delay 3. How it can be prevented: training the local midwives who will remain in rural areas when qualified. So this is very important, the training of the local people in the areas, the midwives, the lady health workers. It is very important to train them. Training nurses, doctors, and healthcare professionals to provide safe births now and for future generations. Ensuring health centers are suitably equipped to provide safe deliveries and improving referral systems between healthcare centers and hospitals. So, the health centers should be well equipped to provide the safe deliveries, and even the referral system should be improved between the centers and the hospitals, so that to prevent this delay which may lead to the maternal death. So if we prevent these 3 delays, the maternal deaths can be prevented. Continuum of care. So this has 2 dimensions: the stages of the life cycle and the places where the care is provided. So the care provided is the community, household, community, and outreach facilities, and then the healthcare facilities. And the life cycle: adolescence and before pregnancy, the females of childbearing age, if they are given proper care, then they will have better outcome for pregnancy and giving birth to a child. And then postnatal care to the mother, and the motherhood, how she bears the child. And then postnatal care to the newborn, care in infancy, and the childhood. So here, adolescence and before pregnancy, if the female is taken care of, then pregnancy, birth, postnatal care to mother, safe motherhood, and then postnatal care to newborn, infancy, and childhood, and to prevent to prevent the maternal death, and then giving a safe motherhood to the mother, and infant is given all the vaccines and taken care of, and so that the child is not malnourished, and the appropriate referral and follow-up, that is from household to community health centers, and from health facilities, the primary and referral care. So these are the links to achieve the safe motherhood. The places of care: giving outreaching services linking the places of caregiving. So starting with the households, then communities where there may be trained midwives and the health workers, and then the health facilities. With respect to the place of care dimension of the continuum, maternal and neonatal care health interventions can be delivered at a household and in community level, and home services provided by the healthcare workers and the midwives through outreach from first level of facility includes immunization, antenatal care, postnatal care, care delivered from at the village health post, first level, and outreach services. Where the antenatal care is given, the postnatal care is given, immunization is given to the children and mothers. At district hospital or referral hospitals, referral level services includes diagnostics, treatment, care, counseling, and the rehabilitation. So district hospital should give a comprehensive health care, and these may include the diagnostic, where a patient is referred for further treatment and care. So I hope you have understood, and if there are any questions, that I think the chat is closed, you can come to me and ask if you have any problem. These are the references. You can refer to your textbooks.
Dr. Maham, you can share your email if you like on the slide, maybe.
Okay, I'll just go through it quickly once again.
Okay.
The basics. So we are discussing the maternal mortality, the Safe Motherhood Initiative. So motherhood is a state of bearing of a child, or state of being a mother, and mainly this initiative was taken to prevent the maternal death. So we did what is maternal death? That is the death of the mother while pregnant or within 42 days of termination of pregnancy. So this is the definition of maternal death, irrespective of the site and duration of pregnancy, by causes related to aggravated by pregnancy and not by accident or incident. Then we went through the causes, direct and indirect causes, and direct causes leading to about 80% of maternal death, and indirect causes about 20%, and hemorrhage being the leading cause, that is PPH being the leading cause of death, direct cause of death in mothers. And then we discuss the problems of the females of reproductive age, pregnant females and children. Then the maternal mortality, how the Safe Motherhood Initiative has led to the decrease in this, and mainly the maternal deaths occur in low and lower middle income countries. And in Pakistan, the statistics are about 186 per 1,000 live births. These are the maternal deaths per 1,000 live births in Pakistan, and we are trying to improve this. Then the Millennium Development Goals and the Sustainable Development Goal that we are trying to achieve the maternal mortality ratio, or decrease this up to 70 maternal deaths per 1,000 live births by the year 2030. Safe Motherhood Initiative, which was taken to reduce this maternal mortality ratio, and it was started in 1987, and in Pakistan this initiative was started in 1990 with the help of WHO, UNICEF, and United Nations Population Fund and JICA. And this is the model of safe motherhood, which includes family planning, antenatal care, obstetric care, postnatal care, abortion care, and STD and HIV control on the base of primary health care and equity for women and communication for the behavior change. These are the foundations. And then we discuss how we are going to provide the facilities for family planning and all these pillars which are important, the antenatal care and the WHO model for antenatal care. We discussed that in first trimester, a female must have one contact or one visit to the antenatal center or clinic. And then second trimester, at least 2 visits, and then 5 visits during the third trimester. The routine functions, then the clean and safe delivery, which is important for prevention of maternal death due to sepsis and infection, and stillbirth attendant, which is very important. Then the essential obstetric care, which includes the basic and the comprehensive care. The basic is provided at the health center, and the comprehensive is at the district level, which is after the referral. Then the 3 delays model we discuss, that where the delays take place and which may lead to maternal death. The first delay in deciding to seek care, the second in identifying and reaching the healthcare facility, and then third, receiving the adequate and appropriate treatment. So if we are able to prevent the 3 delays, we'll be able to prevent the maternal deaths due to these delays. Then the continuum of care, these levels are very important: the household, community, outreach, and then the health facilities, and the care of the female from adolescence, then during pregnancy and childbirth, and then the postnatal care of the mother and the baby. So I hope you have understood, and if there is any problem, you can come to me in the department and we can discuss. Thank you. Thank you, Dr. Sana.
Thank you so much, Dr.
You may